So hopefully we can finish today the adrenal gland. Yesterday we start with congenital adrenal hyperplasia, the problem with zona reticulars. So androgens will be high. We didn't finish it yesterday, so we finish it, then we go to the hypofunction of adrenal gland, adrenal cortex. Then hopefully we have time to finish the adrenal medulla. Not too much today. So can we start?
Yes.
Yes, Doctor.
Okay. Bismillah ar-Rahman ar-Rahim. So yesterday we just started in the congenital adrenal hyperplasia. We finished with the zona glomerulosa, which secrete aldosterone. So we saw what happened when there is hyperaldosteronism, which is Conn's syndrome, can be primary, can be secondary. So primary is the Conn's syndrome, secondary is another thing. We also talk about Cushing syndrome, when there is increase in the cortisol, and the causes. The most important to know is the causes. Always know the causes of what can cause high aldosterone, what can cause cortisol, and the clinical features, very important. And we talk a little bit on the androgens. So this is the common thing is when it is congenital, it is inherited disorder, so we call it congenital adrenal hyperplasia. It's due to enzyme deficiency. So you always remember in the enzyme. I hope you know the pathway of the hormonal synthesis from the cholesterol, biochemistry stuff. So it's inherited disorders, it's autosomal recessive when there is deficiency of the enzymes. The two most important enzymes and the most common is 21 hydroxylase and 11 hydroxylase deficiency. So most of the cases is because of 21, more than 90% is 21. And I show you the pathway for the synthesis of the hormones in the adrenal cortex. So we have three main hormones: mineralocorticoids, aldosterone. This is the zona glomerulosa. The second one in the middle is zona reticular. So the product is the cholesterol. That's why they call it lipid hormones or steroid hormones. And the production is cortisol. And then we have zona reticulars, which produce androgens, male sex hormones. So we have these enzymes, different enzymes. The two you should know is 21 hydroxylase and 11 beta hydroxylase. So in this disease, the patient will have severe deficiency of one of them, usually 21. So we all know the enzymatic reactions. When the enzyme is not there, the reaction will stop or delayed. And the products before the enzyme will increase. So all this before 21 hydroxylase will increase in the concentration, but it has nowhere to continue to produce aldosterone or cortisol. So it will go to the other way, to the left, to produce androgens. And that's why these patients have a lot of androgens in the blood, and it will cause the clinical features or the pathological changes. So we have 21 hydroxylase and beta 11 hydroxylase. The difference is one product will be produced, which is 11 deoxycorticosterone, which, as I said yesterday, have same effect like aldosterone. So here in 11, there is reabsorption of sodium and potassium. So we talk a little bit on 21 hydroxylase deficiency. I go to the pathway first. So this is when the deficiency of the enzyme, the products after the enzyme will be less or absent. It depends on how severe is the enzyme. If we don't have enzyme at all, if the patient have zero concentration of the enzyme, so there is nothing will be produced, aldosterone or cortisol. So the defect also depends on how severe is the deficiency. So this will be the absent. The androgens will be increased, and the effect will be due to low cortisol, low aldosterone, plus increased androgens. So low aldosterone, sodium will loss. So we cannot absorb sodium and potassium. Patient will have hyponatremia and hypotension. Back to the clinical features. So because of low cortisol, As we said, when the last hormone is less, if there is hormone which stimulate that hormone, so here we have CRH and ACTH from the hypothalamus and pituitary. When the cortisol is low, these two glands will be stimulated. Positive feedback, so trying to increase cortisol. And that's why in this patient we have low cortisol, which will lead to increased ACTH. And increased ACTH will stimulate the gland, but there is no enzyme to produce the hormone because the enzyme is deficient. 21 hydroxylase is low. So even though there is increase in the ACTH, there is no production of the hormone because we don't have the enzyme. So the only effect of increased ACTH is the gland will be enlarged, hyperplasia. And that's why it's called adrenal hyperplasia. In this patient, the hormones is low, but the gland is enlarged. So that's why they have adrenal hyperplasia. Low cortisol, low aldosterone, the patient cannot reabsorb the sodium and excrete potassium. So patient will have sodium wasting or sodium lost, means sodium will go in the urine. The blood will have hyponatremia, low concentration of sodium in the blood, but increased sodium in the urine. And this will lead to hypotension. So patient will have hypotension because of loss of sodium. And we have the other effect is increased androgens. Increased androgens, which will cause the male characteristics like hirsutism. Hirsutism means increase the hair distribution. Virilism or virilization means the voice become male characteristics, the muscle becomes bulk, increase in the muscle tone, increase in the voice becomes hard, and infertility. Clear. So this is because of this enzyme. This is the clinical feature we already explained. I don't know where I'm going. The second enzyme is 11-hydroxylase. Here we have another step will be producing, which is 11-deoxycorticosterol. So around 5% of these patients have this enzyme deficiency. So they born, it's inherited, so it's the problem started in the intrauterine life, or the fetus. With less hydroxylase enzyme, 11, so we have one step after 21 hydroxylase, which is 11-deoxycorticosterol and 11-deoxycortisol. These, especially this, the blue one, 11-deoxycorticosterol, has same effect like aldosterone. So the effect of low aldosterone will not be here in this patient because this one can still reabsorb sodium and excrete potassium. So this patient will have hypertension, not hypotension. The first enzyme, 21-hydroxylase, the patient will have low blood pressure. This patient with 11-hydroxylase, the patient will have hypertension because this has mineralocorticoid effect. 11-deoxycorticosterone will reabsorb sodium, excrete potassium. So if this product is increased in the concentration, it will cause hypernatremia, hypertension. Plus there is androgens. So there is virilization because of increased androgens or testosterone in that, but here hypertension. The first enzyme we said hypotension because there is no mineralocorticoid effect. In the 11-hydroxylase we have hypertension because of sodium reabsorption and potassium excretions. Deoxycorticosterone, hypokalemia. The only opposite is aldosterone effect. So when the baby born, usually if the baby the patient is female, it's very obvious, especially since born. So internally she has the normal internal female reproductive organ. The ovaries, the uterus, fallopian tube, everything is normal except external genitalia. So abnormal menstrual when it's gross. This is the most important one, is number 2. Genitals that looks both male and female. This is since the few days of born. So this is, we call it ambiguous genitalia. Means we cannot say this is boy or girl. When it is born with this congenital adrenal hyperplasia, you can see this in pediatric. Sometimes we can see patients in pediatric. Ambiguous genitalia means it is very difficult to differentiate. Is this a male or female? From external, but internally, she has ovary, uterus, fallopian tube, normal, internal, female. Externally, it is more male. Sometimes we need to do karyotype to find XX or XY. Of course, when they grow up, they have deep voice, so the male characteristics will start to appear because they have high androgens in the blood. So deep voice, early appearance of pubic hair, excessive facial hair, mustache, and when it is adult, there is failure of menstruate, amenorrhea. So she will develop primary amenorrhea, means there is no amenorrhea at all. Clear? So this is a female patient with congenital adrenal hyperplasia, where there is deficiency of the enzymes, which will lead to deficiency of the aldosterone, cortisol, but there is increase in the androgens. If the patient is boy, they will not have, because they're already boy, so the male increased androgens at early stage will not be a problem, but they usually enter puberty sometimes within 2-3 years because of massive increase in the androgens. So they become adults very, very early if we don't correct it. Early appearance of pubic hair, early development of muscle becomes bulk, enlarged veins. So clear. So this is for the congenital adrenal hyperplasia. You just need to remember the androgens. How we diagnose? Of course, depends on the clinical features. We have to do blood test. Of course, you will find increased androgens. So increase androgens, increase the products in the pathway. So this one, we can measure, So increase androgens, increase 17 alpha hydroxypregnenolone. This is usually we measure in the blood, the middle one, which will be very, very high. Plus increase androgens, decrease estrogen, 17 hydroxyprogesterone, at least 2 days after birth. Elevation serum of, and of course serum androgens increase ACTH, and low cortisone, low aldosterone. Sometimes we do chromosomal analysis to find the defect, the genetic defect. Clear? Any question for hyperfunction? Any questions?
No question.
No question, doctor.
Okay, so now we finish with the hyper secretion of the adrenal gland. So adrenal gland disorders, adrenal cortex, we are still in the adrenal cortex. Patient have hyperfunction, hypofunction, or mass enlargement. Hyperfunction, Conn's syndrome or increased aldosterone, increased cortisol, increased androgens. Now we go to the adrenal hypofunction. What happens if the adrenal cortex decrease the production of the aldosterone and cortisone and androgens? Androgens, no problem. Deficiency of androgens have no effect because the female don't need androgens. The male, they already have gonads to produce androgens. So if the androgens from the adrenal cortex is absent, no problem, because there are still another organ which produce the androgens. The most important is the female, the gonads. But the problem when there is the deficiency of aldosterone and cortisol. So adrenal hypofunction or adrenal insufficiency, which there is a damage to the adrenal cortex, can be due to tumor, hemorrhage, infection, whatever the damage. When the cells of the adrenal cortex, adrenal glomerulosa or zona fasciculata is damaged, the hormones will be decreased. And this is, we call it hypofunction or insufficiency or adrenal failure sometimes. There are two types, primary and secondary. So primary means the defect are in the adrenal cortex. And this is, we classify into acute and chronic. So sometimes the adrenal cortex function suddenly drop very fast within hours or days, or sometimes takes longer duration. That's why there is acute adrenal insufficiency, chronic adrenal insufficiency. Acute means sudden drop in the function of adrenal cortex and sudden drop in the hormone level. So the problem is sudden, especially when there is hemorrhage, for example, sudden hemorrhage in the adrenal cortex causing sudden drop in the hormone productions. Or the problem can be chronic. We call it chronic adrenal insufficiency. It means the damage is going slowly progressive, and the hormone level are not suddenly drop. It will drop slowly. So the effect will be different. And of course, secondary insufficiency. So secondary insufficiency means the problem is not in the adrenal cortex, but the problem somewhere else, which causing decrease in the hormone. Here, mainly the cortisol. So in secondary insufficiency or secondary adrenal insufficiency, the problem most likely where?
Pituitary.
Pituitary, very good, pituitary. So there is decrease in the ACTH, which will cause decrease in the cortisol. So maybe there is tumor, or there is, you just need to go back again to the pituitary. Any cause of hypopituitarism can cause secondary insufficiency of the other glands. So if the ACTH is low, cortisol will be low. This is what we mean by secondary insufficiency. So the problem can be in the pituitary, or less common can be in the hypothalamus also. Clear? So primary, so this is the causes in general. Huh? This can be caused for any. The three in the red, this is the three most common cause of adrenal insufficiency. And the most common one is the first one, sudden withdrawal of glucocorticoid treatment. Sometimes the patient has autoimmune destruction, the immune system attacking the adrenal cortex and causing damage to the entire adrenal cortex by T lymphocytes or by antibodies, autoantibodies. Tuberculosis, last time tuberculosis is the most common, now less. Sometimes adrenalectomy, so means the patient has another disease, maybe tumor in the adrenal, and they remove the adrenal gland, so there is no more hormones. Or they have secondaries deposited, amyloidosis, hemochromatosis, infection, histoplasmosis, or adrenal hemorrhage. So this is in general the causes of what can cause damage to the adrenal cortex. The first one, this is, you need to understand why when the patient in glucocorticoid means cortisons. So if the patient taking cortisone for a long period, and we all know that there are many people on cortisone because of inflammatory disorders like rheumatoid arthritis, SLE, or malignancy. So this is one of the most common drug we use, is the corticosteroids or anti-inflammatory drugs. When the patient on anti-inflammatory drugs, for example, patient taking prednisolone or cortisone for a long period, what will happen when the patient taking cortisone for ACTH and CRH? Inhibits, yes. So we always see when the cortisone is increased, doesn't matter what's the reason, the ACTH and CRH will be dropped. So when the patient on treatment of cortisone, the cortisone level in the blood is increased, so ACTH and CRH is dropped or stopped, no more production. If the patient stop taking cortisone suddenly, sudden withdrawal means stop cortisone, now the cortisone level will be decreased because they are no more taking, and the hypothalamus and pituitary already inhibited. The hypothalamus and pituitary is not like a switch. It will not act immediately. It needs some time to be reactivated again. So if the patient stops the cortisone suddenly, they will remain for days without cortisone, and ACTH, CRH will not be activated yet. This is the period very, very dangerous because it will cause acute adrenal insufficiency. No cortisone, no ACTH, no CRH. And that's why when the patient taking cortisone, we do tapering. If they have 50 gram, we reduce to 25, then reduce to 10, then reduce to 5 over a period. That's how we stop cortisone or glucocorticoids. They never stop cortisone suddenly. Otherwise, they will enter into acute adrenal insufficiency. And acute adrenal insufficiency is emergency, dangerous. Patient can develop no aldosterone, they will go hypotension, shock, and they can die. So it's emergency situations. Clear. So if the patient on cortisone, never ask the patient to stop taking cortisone suddenly. They must tapering over a long period. So they reduce the doses, and maybe in pharmacology we can explain in more detail. So they reduce because that's the reason why. Because when they take cortisone, ACTH, CRH is inhibited. When they stop cortisone, still ACTH and CRH are inhibited because they need time to reactivate it again. This time days can take. It's not suddenly open and close. Clear? Faham?
Faham.
Okay, so that's why sudden withdrawal of glucocorticoid is one of the most common cause of adrenal insufficiency. But now they know about this one. Autoimmune, so there is autoimmune adrenalitis, means the immune system is attacking the. So we just said there is acute, and this is the primary adrenal insufficiency. Primary adrenal insufficiency, the problem is in the adrenal gland, and it can be acute, can be chronic. If it is chronic, the disease is called Addison disease. So Addison disease is chronic primary adrenal insufficiency or hypoadrenalism. Means there is decrease in aldosterone, decrease in cortisone, and this is causing slowly progressive, and the problem is in the adrenal gland. So this is called Addison disease. It is like opposite to Cushing syndrome. So most of the clinical features will be opposite to Cushing syndrome, less aldosterone, less cortisol. Addison disease is the pathogenesis. So how this developed, it is an autoimmune disease. So it's autoimmune adrenalitis. It is destruction, progressive. You can add slowly progressive destruction of the adrenal cortex. Entire adrenal cortex is destroyed, and the destruction by the immune system, both humoral immunity and mainly cellular immunity is involved. So mainly cytotoxic T lymphocytes. The immune system of the patient respond wrongly. The T lymphocytes will be abnormal in function and attacking the infiltrate, means it go to the adrenal gland and infiltrate the adrenal gland and start the inflammation, adrenalitis, inflammation of the adrenal gland. Plus, around 50% of the patient, they also have O2 antibody, IgG, attacking also the adrenal cortex and start the damage, start the inflammation, which will end up with fibrosis and necrosis and damage to the cells. So this is how Addison disease is developed, the mechanism of the disease. Pathogenesis means mechanism of the disease, how this disease appears. So you just need to say it is an autoimmune disease where there is T lymphocytes, cytotoxic, means CD8 lymphocytes, cytotoxic from the name, it's the cells which destroy the cell. It's the cell which destroys cells. So it's T lymphocytes will destroy the cells of the adrenal cortex. Plus there is antibodies also attacking and starting the inflammatory process inside the adrenal cortex. And this will lead to drop in cortisol, drop in aldosterone. So when there is no cortisol, androgen, as we said, no problem. If there is deficiency of androgen from the adrenal gland, there's no problem because it's only small amount is produced. We still have another organ. But the problem with aldosterone and cortisol. So what the patient develop when they have less aldosterone?
Hypotension.
Hypotension, yes. They will lose sodium. Sodium is lost. So this is started by losing sodium. They cannot reabsorb the sodium. When the sodium enters the renal tubule, normally we reabsorb it back after it filtered from the blood in the glomerulus to go from the glomerulus to the proximal convoluted tubule to lobe of Henle. When it reaches the distal convoluted, there is hormone acted there, aldosterone, to reabsorb sodium, excrete potassium. So these patients have less aldosterone. So most of the sodium will not be reabsorbed from the nephron, means it will be lost in the urine. This will lead to hyponatremia, decrease in the sodium in the blood. And this decreased osmolarity also lost the water, also will follow the sodium out in the urine. So that will lead to hypovolemia, hypotension. And that's why this is the emergency, especially when it is acute, if this happens suddenly. Because patients, when they have low blood pressure, hypotension, hypovolemia, they can develop hypovolemic shock. And you all know hypovolemic shock is dangerous, so it can coma and death later. So this is the main claim, but there's other clinical features. Hypoglycemia also very important. There are others, but the most important is hypoglycemia and hypotension. Dizziness and hypotension is the first thing patient might develop. Plus, you can read these clinical features: weight loss, anorexia, nausea, vomiting, tiredness, pigmentation. Why there is pigmentation? Especially in the crisis of the hands, these lines here becomes very dark in color, or if the patient has scar, the scar becomes very dark, black or brown, dark in color, which is we call hyperpigmentation. Why do you think patient has hyperpigmentation?
Increase ACTH.
Increase ACTH, yes. So this is, as we said, it's a primary problem. The problem is in the adrenal cortex. So there is inflammation, there is autoimmune destruction. This will lead to aldosterone low, cortisone low. Low cortisol will stimulate the adrenal, the pituitary gland. So pituitary trying to increase the production of cortisol by increasing ACTH. ACTH, as we said, it has melanocyte stimulating activity. It will stimulate the melanin production in the body. And that's why these patients will develop pigmentations. So this one, the same, just so the pictures, they are usually patients with Addison are very thin, opposite to the Cushing. Cushing are usually weight gain. Here they weight loss because losing water, losing vomiting, diarrhea. So this is some pigmentation, especially in the elbow. If there is a scar like this scar becomes very, very dark in color. Sometimes inside the mouth, buccal mucosa becomes dark brown in color, hyperpigmentation due to ACTH. Morphology is not very important, but just a little bit to know so if there is secondary, this is not for primary, and this is for all the causes. The adrenal gland becomes small, atrophy. Primary tuberculosis, we can find granulomatous, granuloma. You don't need to remember this one. That's for chronic, huh? The acute. Now we go to acute adrenal insufficiency. Acute means sudden drop in the aldosterone and cortisol. When the aldosterone and cortisol drop very fast, this is emergency. Patient can die because of hypotension, hypovolemia, and shock and hypoglycemia. So there is severe emergency. So it's a medical emergency, acute onset, can be fatal if not detected and corrected very fast because of these, mainly because of these three: severe hypovolemia, shock, and hypoglycemia. So each of these can kill the patient. Hypoglycemia can kill, hypovolemia, severe hypovolemia because of vomiting and urination, loss of sodium, loss of water, hypotension, can be shock. When the patient can develop acute, so usually they have chronic, they have some sort of damage to the adrenal gland, and then they have precipitating factor. So there is maybe a patient with Addison, and then suddenly they get infection or trauma or surgery, which they already have some adrenal problem, understand? So this is precipitating factors. When the patient, for example, have Addison disease and they do surgery and they might enter into acute crisis. That's why precautions must be taken. Or sometimes sudden hemorrhage inside the adrenal gland due to DIVC, disseminated intravascular coagulation, or anticoagulant treatment. When the patient taking, for example, they have heart problem, they take anticoagulant, they might develop hemorrhage somewhere in the body. And that's why with the patient with anticoagulant must be monitored by INR, the level. So if they might develop hemorrhage, acute adrenal hemorrhage, or infection by Neisseria meningitis, meningococcal septicemia, which can cause septicemia in the body, and this can invade the adrenal gland. So this will cause acute adrenal insufficiency, which is a emergency situations. How we treat, of course, any hormone deficient, we just need to give the hormone. So it's a hormone replacement. For cortisone, we give hydrocortisone. This is for chronic, for Addison disease. This is this management for patient with chronic adrenal insufficiency. Hormone replacement. For cortisone, we give hydrocortisone. For aldosterone, we give 9-alpha-fludrocortisone. So this is to replace the aldosterone, which is the drug is called 9-alpha-fludrocortisone, to replace the aldosterone. To replace the cortisone, we give hydrocortisone. If the problem, this is for Addison. For secondary, of course, you have to correct the pituitary, for example. So in addition to give the hormone replacement, you also need to look for the secondary cause. So if there is tumor in the pituitary, we have to remove the tumor, surgical removal of the tumor. So the first part is for the primary damage, the damage of the adrenal gland. We give hormones. The damage, the secondary, in addition to give hormone, you have to look for the primary cause. And for acute, this is we give orally. For acute, we have to give intravenous because we need to act fast. So you give adequate resuscitation, intravenous fluid, because patient has hypovolemia. So we need to correct the volume, increase the volume by giving IV fluid, very, very important. Patient have hypoglycemia, we give glucose, and you have to give hydrocortisone IV, not orally here. In acute adrenal insufficiency, we give IV 100 milligram, this one. I think that's all for hypoadrenalism. Any questions?
No question, doctor.
No, doctor.
No
Okay.
question, doctor.
Last one is adrenal medulla. And so we have finished with the adrenal cortex, the zonal gland, the aldosterone, cortisone, androgens, when it is high, hyperfunction, or when there is deficiency or hypofunction. Hypofunction, you just need to remember acute and chronic. In acute emergency situation, in chronic Addison disease. Now we go to adrenal medulla. Adrenal medulla is different. It's almost different gland. Embryologically, structurally, functionally is different from the adrenal cortex. So this adrenal medulla is exactly similar to sympathetic nervous system. Sympathetic nervous system, yes, because it secretes the same product epinephrine and norepinephrine, which is the act on sympathetic nervous system. But in sympathetic, we call it neurotransmitters. Here we call it hormones. So this gland secrete hormones, and why we call it in the nervous system, we call it neurotransmitter, and here we call it hormone. Even though it's the same product, epinephrine, norepinephrine, in the nervous system, we call it neurotransmitters. Here we call it hormone.
Duration of action?
Okay, so how? Yes. Why duration of action? What's the faster? What's delayed?
Neuronal more faster than hormonal.
Yes, very good. Why? What is the main characteristic of why this product, we call it hormone, endocrine? Why we call it endocrine?
Release in the bloodstream.
Yes, it goes to the blood. It released into the bloodstream. So the hormones is a product produced from endocrine cells or endocrine gland, and it goes to the blood first. Then in the blood, it goes to the target cells. Do we have other products sometimes act paracrine, endocrine, autocrine? If the cells produce product and act in the same cells, we call it autocrine action. If from the cell and cell very close, we call it paracrine. But when the product goes to the blood and in the blood it circulates and it goes to the target cells far away, it's called endocrine. So that's why here epinephrine and norepinephrine from the adrenal medulla, we name them or we call them as a hormone, because from adrenal it will go to the blood and then it will act in the nervous system. It from the neuron to neuron or from the axon to the muscle or so. This very fast effect. Very good. So as we said, it's a modified part of sympathetic nervous system, adrenal medulla. The cells of adrenal medulla is called chromaffin cells. Just additional information, you can read it. There are two types of chromaffin cells we have in adrenal medulla. So the adrenal medulla is the middle part of the adrenal cortex. Epinephrine producing and norepinephrine. Okay, so we go straight away to the damage. What are the main disease in adrenal medulla is a tumor called pheochromocytoma. Pheochromocytoma is a benign tumor arised from these cells. So it's a chromaffin cells. Chromaffin cells, we have cells here, chromaffin because it takes the dye potassium bichromate. So just when this cells develop a tumor, usually benign, capsulated, it called pheochromocytoma. So pheochromocytoma is not very common, uncommon tumor, but just wait for the others to join. Pheochromocytoma. So now we are talking about adrenal medulla. Pheochromocytoma is it's a benign tumor, is uncommon tumor of chromaffin cells. And this chromaffin cells, we just said it's produce epinephrine and norepinephrine. So the same thing, this tumor will produce epinephrine and norepinephrine in massive amount. So the patient will have, it's exactly similar when the sympathetic nervous system is activated. So the patient have overactivity of sympathetic nervous system because of increased catecholamines, epinephrine or norepinephrine, or sometimes both, depends on which cells is affected. Clear, so it's uncommon tumor, it's a benign, so benign, well encapsulated, so encapsulated, lobular, this one the characteristics of benign tumors. So usually a solitary mass in the adrenal medulla, and this mass is well encapsulated, there is capsule, and this tumor secrete massive amount of epinephrine and norepinephrine. So the effect will be overactivity of sympathetic nervous system. In addition to this tumor, also sometimes we find it outside the adrenal gland, just for your, so we have around 90% of this tumor, pheochromocytoma, arised from chromaffin cells of adrenal medulla. But we also sometimes found pheochromocytoma outside the adrenal gland, especially in the neural cells, in the neural crest, in the abdomen. This is called paragangliomas, around 10%. So sometimes patients have a lot of epinephrine or epinephrine, but not from the adrenal medulla, from this 10%, which we can find the same tumor outside the adrenal gland. So adrenal medulla, but mostly from adrenal medulla. We go straight away for the symptoms. So it's a benign tumor, secrete excessive amount of estrogen, progesterone. So you just need to remember the sympathetic nervous system. There is anxiety, panic, heart rate will increase, palpitations, tremor, sweating, headache, nausea, vomiting, weight loss, constipation or diarrhea. Different patients respond differently. So you can see it is all due to epinephrine or norepinephrine overactivity. Especially the heart will affect the heart, tachycardia, palpitation, tremor, sweating, very important in this patient. And signs will have hypertension. Usually patient come with hypertension as the first symptoms. So patient have high blood pressure. It can be constant or intermittent. Intermittent means the patient has high blood pressure, then it goes back to normal. Then after a few days, the high blood pressure again, and then go back to normal, and that's all. Or patient have hypertension all over. A constant hypertension or intermittent. Most of the patient have intermittent hypertension. So hypertension goes up because this tumor secrete, then sometimes stop. The production of the epinephrine from the pheochromocytoma tumor is not constant all the days. So today maybe produce a lot, tomorrow maybe less. So when the tumor cells increase, also increase the production of epinephrine. So that's why the blood pressure is fluctuating or intermittent blood pressure, but it can be constant. So usually patient has intermittent or fluctuating hypertension, means blood pressure is not constant, goes up, down, or few constant. Tachycardia, pallor, flushing, the face and hands becomes flushing or rich, glucosuria, fever. So it's just very easy to recognize these clinical features. Sometimes when you find, just to simplify or to, when you find patient has episodic hypertension or intermittent hypertension, same, episodic or intermittent or fluctuating is the same. Means the blood pressure is not always high. Sometimes high, sometimes very severe high or low, or so that's called episodic. Diaphoresis, sweating, a lot of sweat, and tachycardia. This is a very, very characteristic of pheochromocytoma, classic triad. So if the patient have hypertension and told you he's sweat a lot and heart rate is increased, now you have to think of sympathetic or epinephrine or norepinephrine. So we measure these hormones. Okay, just to don't forget the others clinical feature. Huh? So it's not only these three, but this is the characteristics. Patient has intermittent hypertension plus diaphoresis, means sweating, plus tachycardia, and this is some clue. But there's other clinical features. Sometimes also there is symptoms of B's, they call it B5B. Pressure, hypertension, pain, headache, perspiration means sweating, palpitation, pallor. If the patient comes with these five, the first thing you think of pheochromocytoma or epinephrine and norepinephrine is high. If you find collection of these, let's simplify the diagnosis. If the patient has hypertension, especially if the hypertension is fluctuating or episodic, not constant. If the patient have today, they have very high, after 2 days there's normal, then high, then low, then, so this is very characteristic of pheochromocytoma, but not necessarily patient will come this way. But if you find these 5 B's, this will simplify the diagnosis. Straight away, you must think of this tumor and do ultrasound or MRI or CT scan for the adrenal gland. You might find this tumor, benign tumor in the adrenal medulla. So we need to remove it, especially if there is sweating, palpitation, and intermittent hypertension. There's also rule of tens in this pheochromocytoma. There are 10% of this tumor is located outside the adrenal gland, 10% in the children, so 90% in adults and elderly, 10% familial, so you can run in family. Familial, what we call this one, I mentioned on the parathyroid gland, I mentioned in the thyroid gland, I mentioned in the pituitary gland. Part of what? Cannot hear you. Pheochromocytoma, huh?
Is it multiple endocrine neoplasia?
Very good. Multiple endocrine neoplasia. So this tumor can be found with another tumors like pituitary and thyroid and parathyroid together. So that's why we call it familial. Familial means genetic problem, which cause multiple tumor in more than one glands. This is called multiple endocrine neoplasia. Pheochromocytoma, one of them. Medullary thyroid carcinoma and parathyroid adenoma, and sometimes pituitary. That's why we classify into MIN1, MIN2A, MIN1, MIN2B. So 10% of this tumor can be found with another tumors or familial or genetic problem. 10% bilateral or multiple, which is more in familial, but usually single and unilateral. One gland has this tumor. 10% can recur after remove this tumor. It might comes again in 10%. We just said it's a benign tumor, but there are 10% of this tumor can become malignant, or it's a malignant tumor. So, and 10% discovered incidentally, means patient don't have clinical features, they go for checkup or they do some ultrasound, maybe for the kidney, they find this tumor. So incidental. Clear. So this one just to remember them. Firstly, this tumor is, we just say it's mostly benign. So it's small, circumscribed, lobulated, capsulated, and very well differentiated, similar like to the medulla, but it can be large. So it can be small, mostly small and circumscribed encapsulated tumor. It can be large with hemorrhage inside, necrosis, cystic changes, microscopically, spindle-shaped chromophene cells. This one you don't need to. Okay, that's all for pheochromocytoma, just a little bit on. Of course, treatment is remove the pheochromocytoma plus correct the palpitation, tachycardia by giving. The patient have palpitation, tachycardia, what do we give?
Beta blocker.
Beta blockers. Beta blockers to correct this sympathetic overactivity. So we give beta blockers, and if there is tumor, you have to remove the tumors. That's all for adrenal gland, adrenal cortex, and adrenal medulla. Any questions?
No.
So next class will be on pancreas, diabetes, endocrine part. So hopefully you know about glucose and. So any questions? No questions.
No, doctor.
Okay. Thank you. I need to for the quiz, the last quiz. You can still access the link or no?
I don't know.
I marked it. I already marked the quiz. I'm not sure. I marked it online, so I don't know if you can still access. See if you can access the result. If no, let me know so I can send to you.
Okay, doctor.
Or you want to? I send to you the list all together in WhatsApp.
Yes. No,
Yes.
no, I don't know.
Huh? Now you check the link first. If there is correction there, let me know. Otherwise, I send to you your results somehow.
Okay, doctor.
Okay,
Doctor.
thank you. Tomorrow we have BBL.
Doctor.
Yes.
Yeah, me and Dr. Khalid. So I don't know which group he will decide.
Doctor, I have a question.
You have a question? Yes.
Yeah. Do we have quiz 2 for endocrine, or just quiz 1?
Pardon?
Do we have second quiz for the endocrine system?
Yes, we have. But I didn't decide when. Maybe after Raya, Friday, or within Raya days.
No, 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 no.
No.
No, we want Raya.
So when we do it? Saturday or Sunday after? Sunday. Because Raya will be Thursday, Friday, huh?
Wait.
I think Thursday and Friday next week, the last 2 days of the module. I still don't know when we do the quiz.
Quiz 2.
Quiz 2, yeah.
Okay, pagi Senin tak boleh? Cepet sangat
Tak, pagi Isnin boleh kot.
Boleh kan?
So we can do it on the based on the reproductive system timetable. Actually, there is no slot for quiz 2 for endocrine system. But if you want to do it, can do it on Monday.
Monday, the first day of reproductive.
Day of reproductive system. So we can do it probably in the morning at 8:30, and then because we have only anatomy with Dr. Balkis that day.
Okay. I will arrange with her, and I can take time from 8:30 to 9:30.
Yes.
Okay, that will be nice. Okay, then thank you very much.
Thank you, Doctor.
Thank you.
Selamat Hari Raya.
Bye. Take care.
Syukran.